Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Vivek Subbiah from the Sarah Cannon Research Institute in Nashville, Tennessee, the United States of America. Welcome to this program titled Advancing Precision Oncology, Recent Progress and Future Outlook. Joining me today are world experts and great colleagues, Drs. Elena Garalda from the Vall d'Hebron Institute of Oncology and the Vall d'Hebron University Hospital in Barcelona, Spain, and Dr. Fernando Lopez Rios from Hospital Universitario 12 de Octubre in Madrid, Spain. Welcome.
Thank you, Vivek.
Today, we'll be looking at the latest and greatest advances in precision oncology with a bit of focus in non-small cell lung cancer progress. We also touch down upon key issues in clinical practice and also looking forward to discuss the future outlook for precision oncology. Advances in precision oncology has led to the approval of precision oncology and tumor agnostic therapies, challenging the conventional drug development, which was histology dependent. As we are moving away from the one-size-fits-all chemotherapy era to histology dependent targeted therapy era to the tumor agnostic therapy era, there is a need to establish a minimum set of requirements for a therapy to be eligible for tumor agnostic potential. The ESMO Precision Oncology Working Group proposes a framework to foster and accelerate tumor agnostic drug development for patients with cancer. The ESMO Tumor Agnostic Classifier and Screener, this is what we call as ETAC, is a tool for assessing the tumor agnostic potential for molecularly guided therapies and for steering drug development. Based on this working group proposal, approved tumor agnostic therapies had an objective response rate of greater than or equal to 20% in 2 out of 3 tumor types meaning greater than equal to 4, with greater than 5 evaluable patients per tumor type. The tumor agnostic effect results from targeted driver molecular aberration interplay with tumor-specific modulating biology. What does the ESMO ETAC provide? It provides definitions, the taxonomy. What is tumor agnostic? What is tumor modulated? And what is tumor restricted? What is tumor agnostic? Targeting a driver molecular aberration defines the therapeutic effect regardless of tumor-specific biology. A prime example is NTRK fusions and RET fusions. Tumor modulation. Therapeutic effect on a target driver molecular aberration is modulated by tumor-specific biology. I would say PI3K or PARP are tumor modulated. Tumor restricted. Therapeutic effect on a targeted driver aberration is only present in specific tumor-specific biology content. Something like EGFR mutations, which we'll be talking about specifically during the lung cancer slide set. So this slide shows the tissue agnostic approvals. Today, in 2025, we have 9 agents approved in the histology agnostic or tissue agnostic space. The first drug to be approved was an immunotherapy for a genomic match, which is MSI high or dMMR. Subsequently, we had the same drug, pembrolizumab, approved for high tumor mutation burden, high cancers defined by tumor mutation burden greater than equal to 10 megabase pairs of DNA. The first tissue agnostic drug approval for genomically targeted therapies was larotrectinib in November 2018. Today, we have not 1, not 2, but three drugs approved for NTRK fusion positive cancers, which is larotrectinib, entrectinib, and the latest kid on the block, repotrectinib. After that, we had dabrafenib and trametinib as a first combination targeted therapy to be approved in a histology agnostic manner across all BRAF V600E positive tumors. Selpercatinib was approved for all RET fusion positive cancers. And again, as you can see here, NTRK fusions and RET fusions are picking needles in haystacks. And we're going to be discussing how to test, what to test, and who to test in the next set of slides. We are entering the antibody drug conjugate therapy era. The first ever antibody drug conjugate, TXD or trastuzumab deruxtecan, was recently approved in a histology agnostic manner in all IHC3 plus positive cancers harboring HER2. Again, the rest of the approvals were based on next-gen sequencing. The first ever antibody drug conjugate approval was based on immunohistochemistry, and we'll be discussing about that. So we are entering the targeted therapy approval era, and I leave it to Dr. Elena Garalda to discuss about specific targeted therapy approvals in non-small cell lung cancer and the latest and greatest advances in non-small cell lung cancer.
Thank you, Dr. Subaya. So really, non-small cell has always been the paradigm of precision medicine, and we have also continued seeing some approvals that really show how precision medicine is advancing its field in non-small cell. So just to mention some recent approvals in this field, we've had the approval of lazertinib with amivantamab in EGFR exon 19 deletions or exon 21 L858R substitution mutations. We've seen the approval of cenocotuzumab in NGR1 positive tumors, and also in ensartinib for a new ALK inhibitor in ALK positive non-small cell lung cancer patients that had not received the previous ALK inhibitor. But let's dive a bit more into some of the data that has been recently presented during the last year. I think there was really a lot of excitement with the data of the Mariposa trial published in New England last year. This was a study where EGFR mutated non-small cell lung cancer patients with exon 19 deletion on L85R mutation received amivantamab plus lazertinib versus osimertinib. And you see that it's really a positive trial with a median progression-free survival of 23.7 months in the amivantamab lazertinib arm versus 16.6 in osimertinib. So the most common adverse events of amivantamab and lazertinib were paronychia and infusion-related reactions and rash, but overall it was a well-tolerated treatment. We've also seen a recent publication in New England Journal of Medicine of cenocotuzumab. Cenocotuzumab is being explored in a tumor-agnostic way in a basket study with all tumor types that include patients that have fusions of NRGR1. You can see, you will see in the slides, the different tumor types that were included in the publication. And it's true that the most common tumor types were non-small cell lung cancer patients and pancreatic cancer patients. This has led to the approval in these two indications, non-small cell lung cancer and pancreatic cancer patients, with an overall response rate of 29% in non-small cell lung cancer patients. But we continue recruiting in the rest of the tumor types to try to gain more insight of how this agent really behaves in other tumor types, and we will see if this reaches a tumor agnostic indication in the future. It's also important to acknowledge some setbacks, and in the next slide you can actually see how we have had some negative studies that have also been presented during the recent months. As Dr. Subaya mentioned, we are entering indeed the field of the ADCs, and there's a big expectation of what these agents are going to bring to precision medicine. Even if most of these agents, and we can discuss this also in the discussion later, are still not approved with a biomarker, but are given really to all tumor types of a specific disease. I think there has been some clear disappointment with two studies that have not met the endpoint of overall survival, which we were all wishing for. So the EVOKE-01 study with sacituzumab govitecan versus docetaxel didn't meet the primary endpoint of OS improvement. And also the TROPION-Lung01 study with datopotamab deruxtecan versus docetaxel, although it had a significant PFS improvement, it didn't show an OS improvement. So in fact, both applications for licensing have been withdrawn from the FDA and the EMA. However, I think there's still things that need to be explored with these agents in non-small cell lung cancer patients. And you can see in the Tropion Lung 5 study the results of the same agent, datopotamab deruxtecan, in non-small cell lung cancer patients that had actionable mutations and had progressed on targeted therapies and platinum therapies. And here you can see that the overall response rate was 35.8% in the overall population. But however, in those patients that had EGFR mutations, their response rate really increased until 43.6%. So still, we really need to understand what's the role of this agent in non-small cell lung cancer patients. There's also been some new advances in the HER2 field. So HER2, although not being a new target, we are really seeing some new agents really driving the precision medicine field in the HER2 space. You can see the results that were presented in ASCO last year of the compound targeting HER2 mutant non-small cell lung cancer that it's being studied in the SOHO-1 study. And this is the results of the phase 1 expansion cohort. Still small numbers, so 33 patients treated, but 23 partial responses with a response rate of 70%. And so I think it's really a disease control rate that really reaches 82% with 27 patients having stability of partial response. So really clear data that needs to follow up and mature with more patients. Another HER2 kinase that is being explored right now and has a bit more data is the TKI, songertinib, that is also being explored in the BEAMON Lung 1 phase 1 clinical trial in HER2 mutant non-small cell lung cancer patients. And you can see here an impressive overall response rate of 71% and with a relatively benign safety profile with mainly some diarrhea, liver enzyme elevation, and some rash, but also impressive data that follows and continues accrual. So I think it's really clear that precision medicine it's proving and continues proving some benefits. The challenges still remain about how we test and what technologies we have and the advances that we have. And for this, Dr. Fernando Lopez Rios will continue discussing how and what we can do currently. Thank you, Fernando.
Well, thank you very much. Hello, everyone. Delighted to be here with Dr. Aralda, Dr. Subia. And yes, I think we are at a very exciting moment, but I think the main challenge is how to integrate all these technologies to make sure that all of our patients have as much information as possible in as little time as possible. So first we have immunohistochemistry, which was kind of a forgotten method, but now is making, I think, a good comeback as a potential biomarker for some antibody drug conjugates. So with immunohistochemistry, we're going to be looking at protein overexpression. Then still sometimes FISH is useful to identify amplifications and fusions. And finally, any PCR-based method from real-time PCR to next-generation sequencing are good methods for literally everything. So we can identify mutations, which are now called variants. We can also, I think now reliably, score copy number variation. And finally, we can look for fusions, particularly if we are using an RNA-based PCR method. So that's a brief overview of all the methodologies. Of course, there are many different options. And we really need to understand when we implement, order, or interpret a result, which technology has been used We have to make sure that we consider the pros and cons. Of course, there is the traditional limit of detection, sensitivity. There's also specificity. But today I wanted to focus on diagnostic sensitivity, which is the width, the breadth of the assay. That is really important. So I also wanted to emphasize that we sometimes need to combine several methods that is called molecular redundancy to make sure that we are not missing an actionable target in our patients. And finally, and I think this is very very new and exciting, and I think probably we are going through an AI um, hype cycle. It's the possibility of using artificial intelligence algorithms to score some of these predictive biomarkers. Specifically, I wanted to highlight how we have been using these biomarkers to score, for example, PD-L1 or tumor infiltrating lymphocytes as potential biomarkers for immune checkpoint inhibition. But now we also have the possibility to score immunohistochemistry as a potential biomarker for some of these antibody drug conjugates. So this is, I think, reality now, or it will be soon. So we have to accept the fact that we might be welcoming a new member at molecular tumor boards and clinical tumor boards, which is the artificial intelligence algorithm. So in summary, I think lots of technologies. I think many biomarkers, and we need to make sure that we make the most of them, uh, making sure at the beginning, with the first sample that we receive, that we preserve those samples for biomarker testing. That is very very important, and it's not only about tissue, but we also need to align and integrate the results from liquid biopsies. And I think that this is exactly where the barrier or the difficulty is, making sure that we integrate so many different technologies coming from the results um, of tissue biopsies and also liquid biopsies. So maybe now we can have some time, Dr. Subia, to discuss when to test, how to test, what to test, or who to test. So let's see what we all think about. I think that the most important questions in the field, probably.
Absolutely. Thank you so much for bringing this. Essentially, we see that we have great drugs, we have great targets, but we need to know when to test, how to test, what to test, and who to test. So, when to test? Again, as medical oncologists, we rely on our multidisciplinary collaborators, including a pathologist, for navigating the field of precision oncology. Because navigating the field of next-gen sequencing and precision oncology can be quite complex. So the first question is when to test, right? My personal opinion is testing should be done at initial diagnosis to identify genetic mutations that may guide treatment decisions. Test should be done for treatment selection, right? We need the test to be done before starting any therapy so that we can choose targeted treatments or immunotherapies based on genetic profiles. We need to test for monitoring, especially liquid biopsy technology, because we need to test periodically during treatment to monitor response and detect emergent resistance mechanisms in these patients. We need to test at relapse or progression, right? Again, we can do liquid biopsy or tissue biopsy upon disease progression or relapse to retest to identify new mutations or resistance mechanisms. And the next question is how to test, right? So I think I leave it to our expert pathologist here, Dr. Lopez Rios, on how to test this. Dr. Rios.
So I completely agree with you. I think we need to really organize um, reflex workflows, very lean workflows, and I think it's a really good idea. First, to make sure that everyone understands how important it is to balance diagnostic immunohistochemistry versus biomarker testing. What I'm trying to say is, I think we need to preserve, as I said before, those samples for biomarker testing, and then I think it makes sense to start by running out all the immunohistochemistry assays first. Then extract DNA and RNA for comprehensive genomic profiling. I think that is a pretty lean workflow for tissue biopsies. And alongside this, uh, I think it's also very relevant to have a strategy for liquid biopsies um, that is in complete synergy with the tissue biopsy effort. So I think if you're really able to organize these two workflows, uh, probably you are going to make sure that most of your patients have all the information that is needed the first time they sit down with an oncologist. I know it sounds uh, easy, but it's obviously not that easy. But I think we need to start by organizing strategies that can be implemented in very different settings.
Yeah, thank you so much. So we discussed about when to test, how to test, what to test. And coming up to the question of who to test, right? Again, my personal opinion is we need to test all patients with cancer, right? To tailor therapies based on genetic profiles. Cancer is a genomic disease. We need universal genomic and germline testing to win the war against cancer. But in the real world, we need to think about testing patients with refractory or metastatic cancer and then clinical trial candidates, right? Identify patients who may qualify for clinical trials based on specific genetic alterations, and also high risk individuals to test, with a family history of cancer or known genetic predisposition. So incorporating precision oncology and NGS into precision oncology requires a strategic approach with multidisciplinary teams balancing the latest technology advancement with clinical insights to achieve the best outcomes, for our patients here. So as we move on, we have some key questions for, clinical practice. So there are challenges, right? Complexity in interpreting test results, challenges in implementing molecular tumor boards, and disparities in access to technology. So let's tackle one by one. First question is complexity in interpreting test results. We can talk about that, and then perhaps Dr. Garalda and I can discuss about how we can communicate these test results with patients. And Dr. Lopez Rios, do you want to talk about complexity in interpreting these test results?
Yes, I think this is a really timely question because because the complexity is increasing, and I'm not sure we are all really educated to read and interpret and integrate all those test results. So I think the first strategy would be to try to um, emphasize the importance of standardized reporting, because then if you're using checklist and reports that have sections that are easy to read and easy to discuss at molecular tumor boards, the clinical tumor boards, I think that's a very important first step. And then the second step, I think, is to use some of the repositories, some of the web pages that are really helping us understand how we are going to be using those results. I'm particularly fond of the ESMO classification, and also I use OncoKB quite a lot. So I think there are many of these tools that can you make your life easy. But I would really focus on those two things. So trying to make sure that the reports are user friendly and standardized, and then make sure that you have access two or three of these web tools that can really help you understand the pathogenicity and the actionability of the biomarker results.
Thank you so much. The next thing is communicating this with patients, right? So simplifying this complex information is very, very challenging. Translating all these technical genetic findings into understandable language for the frontline clinicians, and most importantly for patients, it's challenging. It's crucial to explain how these results impact treatment options and outcomes. There is an emotional impact, right? Genetic information is overwhelming for patients, right? Carrying implication sometimes not just for the patient, but for their family members as well, right? If you identify BRCA1, BRCA2 mutations, that can impact their family members. So providing empathetic counseling is key. Shared decision making, so engaging patients in treatment decisions is also key. And again, we can go on talking about this topic. So moving on to the next topic, let's talk about molecular tumor boards, right? So Dr. Garalda, let me open it up for you to talk about molecular tumor boards, the challenges of molecular tumor boards.
Thank you. I mean, as you mentioned before, I mean, I think precision medicine is a change of mindset. I think finding these alterations sometimes can be frustrating because you don't find that many, because you don't know what you find. So I think there's been a lot of tools trying to decrease the frustration of not being able to interpret a result, or not understanding certain results, or not knowing when you have certain mutations. And I think the appearance of the MTBs has been a very useful tool for the implementation of precision medicine. However, there are a lot of challenges. There are a lot of challenges mainly because it's really a multidisciplinary process, a lot of people that need to be involved. It's time consuming. Once you have to discuss a patient with all of the variables. Once you have a proper MTB, you really see you can discuss very few patients. So it's difficult, and sometimes it's even difficult to access an MTB. You may be in a hospital, in an academic hospital, where you have regular MTBs where you can discuss patients, but sometimes there's no access to a proper MTB. So that's why the challenges still occur. I think right now with artificial intelligence, or even with digital support systems that are helping in the MTBs, we will see some of these challenges addressed. But I think it is important to have, as Dr. Lopez Rios was mentioning, a report that enables the MTB to be as lean as possible. You can depend to a certain degree to the MTB, but many things need to be already included in those reports for the MTBs to really run smoothly and discuss doubts, questions that go beyond a report, or beyond what the people in the lab can actually do, and not only discuss some of the alterations of the test results that should be included in the report. So a lot of value in MTBs, a lot of new systems being applied in the MTBs, and just the urge that if you have a report and there's some doubts, there's always people or systems where you can address, and it's really in the interest of patients to really go through that report in a thorough way.
Yeah, no, I completely agree. I think, for a broad audience, seeing this MTB's molecular tumor board, it's like putting a huge symphony orchestra together, right? So again, you need require oncologists, genetics, pathologists, bioinformatics, several specialists, sometimes pharmacologists to get our drug acquisition specialists, as we call, so that we can access these drugs. Aligning all these people is crucial, yet challenging, and there is lack of uniform guidelines. How do we integrate this seamlessly into clinical practice? Who has the time and the resources to get these in-depth discussions? So that's going to be a major question for us, right? Coming to that, the next one is disparities in access to technologies, right? So of course we have geographical barriers, right? In the US we have urban versus rural, but when we are talking to our European colleagues and across the side of the Atlantic and globally, right? Latin America, Asia, Australia, there is global inequity, right? Access to precision oncology technologies is uneven across all these countries. We need to think globally, act locally. And of course, there are economic disparities, insurance coverage across the board, even in the so called developed countries. Most importantly, education gaps, right? Addressing the education gaps is important. Education gaps among providers, among the physicians, among the oncologists. There is a need for ongoing education for healthcare providers, oncologists, the teams, right? Because all these are moving targets for clinicians. There are new and new mutations, new and new alterations being discovered, new and new drugs are being approved. So this targeted therapy or targets are moving targets for clinicians. How can the real world oncologists keep pace with all these challenging advances? So that is the disparity in access to all these technologies. Again, we'll talk about the future outlook. So one of the major challenges in the clinic, right, what Dr. Elena Garalda and I are both clinical trialists here. Again, we it's a clinical challenge for us for addressing clinical drug resistance. And how do we tackle this in the clinic? Of course, we can do a lot of lab-based studies looking into resistance mechanisms, but how do we tackle that in the clinic, right? Again, Dr. Garalda, again, let's talk about how do we tackle that, in the clinic.
Thank you. I mean, I think, of course, drug resistance is one of the key problems that we have in the treatment of tumors and oncology and the appearance of drug resistance. I think there's a lot of knowledge that is coming from the labs. There's still a big question on how do we implement that knowledge in our clinical practice. And of course, we have combinations, and this has been probably one of the measures that we've had, even with chemotherapy, of combining chemotherapy to address this drug resistance. But how do we do this in a systematic way in a precision medicine field? I think this is something that we are still learning to do. Combinations, rational combinations, the application of artificial intelligence to drive these combinations and to develop in an easier way these combinations is something that, well, I really hope we see advances in the near future with digital twins and artificial intelligence algorithms in general. We've already seen how technologies can help with this. For example, with applying liquid biopsies and being able to capture in a quick way mutations that are driving these mechanisms of resistance, and being able to combine or add a drug or even switch therapy in a quick way. This is something that is already in the clinic for certain tumor types and in certain settings. But how do we apply this in a global way, and how we um, um, combine drugs, sequence drugs in order to address resistance? I think it's going to be critical for the future.
Well said. I think, again, and I think about this, right? Clearly, you talked about combination therapies, right? Combining multiple targets that target different pathways with, combinations of targeted therapies with chemotherapy, other targeted agents, immunotherapy, antibody drug conjugates. So we can enhance efficacy and potentially even delay resistance. Sometimes, like sequential therapy, right? Alternating between different therapies can prevent or overcome resistance. And again, as early phase drug developers, dosing. I think dosing is important. Modifying the drug dosage, and sometimes with different schedules, we can maintain efficacy while minimizing resistance. The key here is, as Dr. Garalda said here, identifying the resistance mechanisms. Sometimes, we forget that we need to have biomarker driven approach to predict and monitor resistance, can make timely treatment adjustments, right? So we are seeing more and more of this timely biomarker driven approaches. So again, let's talk about the future outlook. I think I can ask Dr. Lopez Rios to talk about the future directions in biomarker testing.
Well, thank you. I think probably there are two things that I would like to address today. The first one is that I we are very close to this idea of having NGS and comprehensive genomic profiling part of routine clinical care, using larger panels for most of our patients with solid tumors. So I think that is happening, and probably moving to earlier stages, I think is going to have a major effect on overall survival. So reflex testing at diagnosis for all patients, regardless of a stage or histology. And the second one, and no surprise, is the possibility of incorporating some artificial intelligence algorithms for prediction of actionable targets or scoring of a protein overexpression, for example. I think this is going to happen in the next few years. So we need to make sure that we align our genomic efforts with this new possibility of computational pathology.
All right. I think it was a fantastic discussion among great colleagues here. So, in summary, so what have we discussed so far? So, we've talked about advances in precision oncology that led to the approval of tumor agnostic therapy. So, we have 9 tumor agnostic therapies approved now. And my prediction is hopefully in the next 50 years, we'll have 50 of such drugs approved so that oncologists can deliver precision therapies to patients across the board. We also spoke about non-small cell lung cancer, which is a poster child of flagship of precision oncology. We have new drugs or new combinations of drugs for old targets, which is the amivantamab and lazertinib for EGFR positive lung cancer. And we have new targets with new therapies, new targets like NRG1 fusions and new therapies like zenocotuzumab. Again, fantastic data, not just in lung cancer, but also in pancreatic cancer and also in multiple solid tumors, including very rare cancers. But the challenges we face, we also discuss about the challenges, right? Precision oncology faces challenges in interpreting complex next-gen sequencing data and communicate results to patients. We also discussed about the molecular tumor boards, the need to implement molecular tumor board, but disparities in access to technologies further complicate the landscape. We also spoke about strategies to tackle drug resistance in genomically targeted therapies and immunotherapies. Another key highlight here for this entire session is AI, artificial intelligence. I think artificial intelligence is poised to change precision oncology in an unprecedented manner, in a manner we never thought before, so that we can get the right drug to the right patient at the right time, which is the central dogma of precision oncology. Addressing this requires a multidisciplinary effort and ongoing adaptation to understand the evolution of cancer biology and treatment responses. Thank you so much, Dr. Elena Garalda and Dr. Fernando Lopez Diaz, and thank you for participating in this activity. Please continue to answer the questions that follow, and please do complete the evaluation.
This program was presented by Medscape Education Global.